All right, we're going to get started. It's at noon. And welcome to another session of the ETGC, the East Texas Geriatric Education Center Consortium Topics in Geriatrics series. This is our second session. In January we started this, and this is a series we decided to cover, in general, a very general way of looking at healthcare in the older patient. I'd like to acknowledge our partnership with the Texas AHEC East and our consortium partners that I'll introduce briefly in just a second. As you know, that we are funded by HRSA, and this is one of our required activities and also one of our most popular, I think. We have a webinar access with a link, and if you download QuickTime, you can get a version of this for those that at some point you need to go back to your computer and you want to be able to see the rest of it. We can get a webinar access for you. This is kind of important because usually these sessions go for 3 hours, from noon till 3. Today's session is only going to be 2 hours. One of our speakers couldn't make it. So we did a little bit of creative juggling, and we now have a 2-hour session. And it kind of worked out because this session will focus on social factors related to the experiences of caregivers caring for those with dementia. Both topics will cover very unique types of situations and really good information, I think, that will be helpful to health providers and students. We're going to, after my introduction, we'll have our 2 presentations, and then there's plenty of evaluation forms for you to take care of. As far as forms, this is the evaluation. We appreciate everybody filling out one of these general evaluations so that we can get some feedback to improve our programming. And also, we have a form that is very much required for us for our data. This is a participant profile form. We need to get these back if this is your first time participating in one of these with us. Well, as I mentioned, that this is a series. We have it's 4 in this series on the 3rd Wednesday each month. We will not have one in March since we have spring break, and it just kind of gets in the way of trying to get everybody here. So we'll have the next one in April, looking at surgery in the elderly, and finally in May, nutrition and oral health. I'm going to add a 5th one to make up for today's in June, and we're going to be covering medication use in the elderly, and that's going to be an overview, like what's new in medication use, very important topic in polypharmacy, pharmacology, and also substance abuse and medication addiction. All right, so that will be in June, and you'll hear more about that later. This is the purpose. I kind of mentioned a little bit, looking at the social factors that caregivers may be going through when dealing with or providing care for their loved ones with dementia and Alzheimer's disease, things like that. And our learning objectives, this is in your handout, and you should be able to see that. We will cover these objectives. We are video conferencing to our consortium partners, and we have 5 of them, and I'm going to show you them here real briefly. Okay, we have Victoria College here in the upper left. Next to them in the upper right corner. Hey, they're all left. Aren't they great? I just like it. Yeah, that's what we like. Enthusiasm. Those not waving yet, but will be, is SFA in Nacogdoches. Hello, SFA. Welcome. There you are. Great. Okay. In the lower left corner is Lamar University in Beaumont. Hello there. That might be Dr. Carroll. All right. Welcome. And here, this is Weiss County Health Center. I don't know the exact name. They are a new location. It was Weatherford College, and they always have a very enthusiastic group. And welcome, Weiss County. All right, excellent, very good. Also online, and you can't see them or hear them, but they can hear us, is Baylor University in Waco. We provide free CEs for this session. We have continuing nursing education credits for RNs and LVNs. This will be for 2 CNE contact hours. There's a link on a SurveyMonkey where you'll be able to request your certificate, complete the evaluation form. You need to sign in, and you must be present for the entire session to obtain credit. And this is a little bit more on the instructions on how to get your credit. And I need to let you know that none of our speakers today have any commercial affiliations to disclose that are relevant to the presentation. There's your disclosure. No conflicts of interest have been identified. We also provide social work CEUs. This will be, I'm sorry, that should be .2 CEU contact hours. There's a sign-in sheet and a social work evaluation form and registration form that you can find on the table if you haven't already. Okay. And also, we have CEU credits for physical therapy and occupational therapy. 0.2 hours for that as well. Are there any questions on C&E before we get started? Okay. Well, I really would like to thank our speakers before I even get this started, because this was something we had to put together pretty quickly, and they stepped up. And these are I mean, and when you're talking about social factors, I mean, you got to have social workers, right? Right? And we have two of the best that I know. And so Adele Hertzfeld, she's a senior social worker at UTMB, and she's presented for us before. She's currently the geriatric outpatient social worker and does a lot over, I think, the Victory Lakes clinics and some other clinics around Galveston County. She regularly interacts with patients and caregivers dealing with the realities of dementia. She's co-facilitator of the local Alzheimer's Association sponsored support group and UTMB educational seminar for caregivers of persons with memory loss. Joining her today as a first-time speaker for a GEC event, which I'm very pleased to introduce, is Miss Alice Williams. She's Executive Director of Libby's Place here in Galveston over by Moody Methodist Church. Established in 2001, Libby's Place provides answers to Galveston County's growing needs for nurturing affordable senior adult daycare, and it's been going on for over 10 years. I know this place is great. I mean, it's such a service, such a needed service in Galveston. And they provide transportation for those that can get there, and she could tell you much more about it. I won't take any more of their time. So Alice and Adele.
Thank you, everyone, for coming today. It's the Alice and Adele show, as we like to call it. And our hope is that you will gain some information and some insight to better care for your older adult patients and their caregivers. And before we get serious about things, I just want to share a little humor. At least it's humorous to me. Hope it is to you. Little senior humor. Some seniors are on a bus trip, and the bus driver's driving along, and one of the ladies comes up to the front of the bus, and she hands him a handful of peanuts. He says, "Well, thank you." Munching on them, keeps driving. About 15 minutes later, she comes back up to the front of the bus and gives him another handful of peanuts. She said, "Here to keep you going." "Well, thank you, ma'am. Appreciate it." Keeps driving, munching his peanuts, and another 15 minutes or so goes by. She comes back up with another handful. He said, "Ma'am, if you don't mind me asking, I appreciate the peanuts, but if you don't, eat them, why are you giving them to me?" And she said, "Well, we don't eat the chocolate on them. We only eat them." I'm sorry, I blew it. We only eat the chocolate on them. Sorry, I blew my punchline. Anyway, so we have some humor with our seniors, and sometimes things get a little less humorous when we're dealing with seniors, and that's what we're here today to talk about. And our focus is about memory loss and how it affects families, especially family caregivers. So our goals. We want to look at identifying awareness of the challenges that caregivers face, because a lot of times caregivers are not real open about talking about what's really going on. And we also want to talk about who the caregiver might be in the family and beyond the family. A lot of times it's not even a blood relative who might be a primary caregiver. Also looking at resources for caregiving. A lot of us are familiar with the traditional ones, with clinical care, medical care, but above and beyond that. And also looking at commercial resources. As you well are aware of, there are a lot of online resources, there are support groups, there are resource guides, so we're going to cover a little bit of that toward the end of our talk. And then what we like to call filling your toolbox. This presentation was originally designed for family caregivers when we first presented it. And when Tony contacted us about coming today, we said, if you don't get a chance to go to those same activities, a lot of times you're presenting as other professionals at a caregiver conference, we want to share with you what we're talking about with them and some of the issues maybe that they bring up and the questions they have and the discussions that we've shared with them, and we hope you'll do the same with us today.
Okay, some of the key considerations. White hair syndrome. I can't tell you how many times I'm interacting with another professional. The patient has white hair, and there's an assumption, sometimes by that person, that this person with the white hair is demented. Only about 50% of people age 85 and at age 85 have some form of dementia. So chances are 50-50 when you're talking to somebody older. And you never get in trouble if you interact with them in such a way that you think that they have full cognitive ability. Never get you into trouble. So white hair has nothing to do with cognition. Then types of memory. The two types of memory that we're interested in are short-term memory and long-term memory. A lot of caregivers mistake, they can't remember what they did yesterday, but they can tell me every classmate they had in kindergarten. And that's the way it works with dementia. The last in is the first out. So it's common that families start recognizing we might have a problem when when their loved ones are forgetting to take their medications. Oh, I already took it. Or I'm not supposed to take those medications, that the doctor changed them, or that the pharmacy, the shape and color of the pill has changed. So things get interesting. Types of dementia, the most common or most diagnosed is Alzheimer's. But then we've got Lewy body disease and frontotemporal and vascular dementia. But then there's many, many more. But we focus on the behaviors that seem to be common among all of the dementias. They might present just a tad differently than compensatory skills. The higher the education or the more socially adept the person is, the better they're able to hide their memory problems. They'll turn questions around. When you ask a question, that's a very good question. What about, they turn it around on you. So it gets very interesting because sometimes families don't recognize that there are memory problems. A lot of people that I run into, other professionals, there's subtle characteristics that can clue you in. We might have a memory problem here, and then you can pursue that further. The wall is one of my favorite things. For both of us. Every person has a point at which, or every caregiver has a point at which they can no longer provide care for whatever reason. The stress load has gotten too big. Maybe their health their personal health is suffering. And it's important to know where that wall is so that as you approach the wall, you can start looking at some of the resources in the community to decide what your next step is. I've run into families that as soon as their loved one gets a dementia diagnosis, they've hit their wall and they're looking for residential care. I've got other families, they never seem to hit their wall. It's very different from family to family, caregiver to caregiver. And then definition of family, it's kind of the village. You've got your nuclear family and your extended family, but then sometimes there are friends and neighbors who are part of the family. maybe social organizations or churches that you participate in, that there are members there that you consider your family. So it's not just the nuclear family that we're necessarily talking about. Okay.
First and foremost, though, is identifying that there is a problem. And as Adele stated, a lot of times family members either don't want to admit or they want to gloss over a problem that to an outside person might be very obvious. So that's where we start. And just identifying, the problems come in a myriad of ways. Sometimes it's behaviors, sometimes it's mood. Sometimes it's personal hygiene, personal care. Sometimes it's a change in activities. If a person becomes more withdrawn, doesn't show an interest in things anymore, doesn't have that initiative to get outside and take the walks that they took every day for the last 50 years, things like that. It can be a behavior that's possibly dangerous to a person. Wandering is one of those. Driving is another that we're going to touch on. But that loss of interest in the social activities a lot of times is very significant. And people just say, well, they're getting older. I guess that's normal. Isn't that normal that people get older and they're just not as active anymore? And we say soundly, no, it's not. That can be a significant part of memory loss. Then, of course, overcoming denial, sometimes from the person with the memory loss and also from the caregiver, or that group of caregivers that we've referred to. If you've ever talked with a person that's in denial about anything, you understand how powerful that can be and how important it is to break through that.
Okay. We commonly hear from caregivers, I'm the only one who can help, or patients will tell me, I have no children. I don't know what I'm going to do if I need help. There may only be one child that the child is expected to do it or to be present and provide care, but they have no backup. I had a family member that said, I've got 9 brothers and sisters. I'm the one not working, so I've been appointed to be mama's caregiver or daddy's caregiver. There are caregivers that live away. And they're not seeing the changes in their loved one day to day. They come in maybe once every 3 months or 6 months. Lots of caregivers, I work, I can't take time away from work. So that creates some challenges. One of our favorites is that the caregiver says, I'm the only one who can do it right. Mm-hmm. Well, there's more than one way to do things right. Maybe they don't do it exactly the way, maybe the other doesn't do it exactly the way the primary caregiver does, but it doesn't mean that it's wrong, and it doesn't mean it's not appropriate. And as I said, story of a brother who called his brother and said, well, if mom needs this, you're going to have to do this because you're a nurse. And it's like, no, we don't go there. One thing I do not expect is family members to provide bathing and toileting care for their parent. I just don't expect that. But some caregivers, some children are able to do that. I go where they are. Okay. Moving right along.
So it's a very personal choice about people handling different difficult situations and different situations in their own way. And what we want to do next is share some of those situations that we have actually come across in our years of experience in caring for elderly people with memory loss. Some of you, I'm sure, are very familiar with this issue of taking the keys. When is it time to stop driving? And in this particular situation, this gentleman was a very brilliant, eccentric man. He was an antiques dealer, a lover of art, a community activist. He had a very interesting life. His wife, very artistic, a musician, lovers of the arts. They traveled. They were very active in their community, even in international travel. And Albert, we'll call him, was from the Ukraine. Late in his life, his wife noticed just subtle changes in his mannerisms. And it was some of the things we talked about earlier. He just was more secretive about things. He was in contact with old friends, and he went out to his regular meetings. And so she said, well, maybe I'm just being a little too vigilant. I'm just watching a little too carefully. I'm seeing something that's not really there. But over a period of about 2 years, she saw more changes. The decline in his personal hygiene. He started refusing to take medications that were prescribed to him. He became paranoid and was seeing a physician for it, but then started refusing to see the doctor, and then pretty much stopped taking the medication. Then his wife noticed the disorganization just in daily activities. Routine things, getting up, getting dressed, having breakfast, became very confusing and disorganized. All through this, he was still driving his car. And he would leave the house early in the morning, as he routinely had for many years, but she really didn't know where he went. He would tell her where he went. And a close friend told her that he had become lost driving home in their hometown, which was here in Galveston. And he had driven around for an entire day trying to get home. So, of course, what did she do? She asked him, did you get lost today? No, I didn't get lost today. It was a great day. I went and visited my friends. He got angry at her and would not give up the car keys. So she started watching a little more closely. She saw dents, scratches in the car, but he'd always brush it off. Somebody else did it. I was in, the Walmart parking lot and somebody hit the car. You know how it is. So his wife became very concerned, but again, he would not turn over the keys. Now this is a caregiver. They had no children. Only the wife's sister and elderly mother who lived far away in Florida, and his family who lived in the Ukraine. And this particular caregiver felt very, very alone. She turned to people at her church for advice. She also visited with the social worker, which was me at the daycare, seeking advice and support, trying to get her husband to engage with other people. But he became very paranoid, more so, and then he started threatening her when she would try to take him to get help, take him to talk to somebody. She even called the mental health deputies at one point, and they came and interviewed him, but they determined he was not a danger to himself or others, and so did not make an intervention at that point. Most of you are probably familiar with the mental health deputies, and that's kind of their determination if they intervene or not is a danger to self or others. Pretty quickly after that time, he took off in the car. The car disappeared, he disappeared. His wife was just frantic looking for him and had no idea where he went, and was just trusting in God and what Albert told her, that he was still just driving in the neighborhood. But he was gone for a couple of days. And then she got a phone call. The phone call came from West Texas. And it was the Department of Public Safety in Eagle Pass, Texas. And they had her husband in custody, so to speak. He had been found in a store on the Texas-Mexico border, trying to pass into the border, was entirely disoriented, confused, didn't know where he was, where he came from. Fortunately, had his identification on him, and they were able to contact her. So at that point, she had to make some very difficult decisions and did decide to move him into assisted living. She actually took him to Florida and sought the family support that she really needed to make those decisions and changes. And her family was supportive, and that was how that story came to end.
That was a scary story, because
very scary.
We're co-facilitators of the support group, and she had come to support group the night he went across the causeway. And
not
she
knowing
insisted, oh no, he promised me he won't leave the island. So that had a good outcome. But those the silver alerts that you see driving on and off the island, that's a senior with memory problems who's not where they're supposed to be. Okay, the cruise not taken. The bucket list. That was a big movie, and people started putting their bucket lists together. This couple always wanted to take an Alaskan cruise. And in April, the husband was diagnosed with the early stages of dementia. And so the wife said, okay, we got to go. It's time to do our bucket list. So she made the arrangements. They're headed to their Alaska cruise. They're on the airplane an hour out of Seattle, and he lost it. Sometimes if you listen real close to the news, They'll say a plane had to suddenly land because of a passenger becoming unruly. And I always wonder, is that a demented patient that just couldn't handle the environment? It was too different, too much stimulation. So anyway, they're on the airplane. He gets upset, starts creating problems. The wife becomes scared when they land in Seattle. They made it to Seattle. They didn't have to divert. But there's law enforcement and medical professionals waiting for them at the airport. They don't take the cruise. They haul him off to the hospital to start treating his agitation and all. But he's being taken care of in a strange place by strange people who don't know what his history is. And this was a relatively new diagnosis. He's only had the dementia now for about been diagnosed with the dementia for 3 months. Well, they finally get back. He's heavily sedated. They come in the clinic. This patient had a very fast trajectory. From the time he was diagnosed in April, in October he was dead. It was extremely fast. One of the fast. I've seen one other that was fast like this, and they both happened about the same time, but it was really strange. That bucket list, don't wait. When you've got the time and courage, people that you come across who have big plans, don't wait until your 80s or all. If you've got the money, do it while you still have your health before there's a possibility of developing a memory problem, because it's very confusing. All the strange people, the strange place, the pressurized air, cabin in the airplane. It's just too much to try and explain to the person with memory loss. Now, unexpected dangers. In the clinic one morning, the nurse practitioner got a call from a wife who said she woke up and her husband was standing over her with a large kitchen knife. She was scared. I understand. I would find that scary. And she secured all the knives after that. But there was still concern. Is he going to find something else? And he got kind of angry when he couldn't find the knives anymore. Had a son. He and his wife were taking care of his father. And they were at the top of the stairs. The son was getting ready to come down. Dad came behind him and pushed him. And he fell down the stairs. Didn't have any serious injuries other than being scared that I could have been seriously injured. I had no reason to think Dad would do this. Haven't heard from them. I think shortly after this, they got Dad into residential care or moved someplace without stairs. And then we had another family in the clinic that they knew they needed to remove the guns from the house. And they did. And then Dad realized the guns are gone, and he got very upset and very aggressive, violent. And the family brought the guns back. It was like, that's not such a good idea. But at least they had them unloaded, and there were no bullets available to him. But these are all things to think about. And we have a culture that's big on guns. As you're working with people, when I worked hospice, my nurses would go crazy when they found out that our patient had a gun. Well, there's lots of guns. And as long as the person is not threatening or verbalizing suicidal or homicidal ideation, there are ways to secure the guns and make sure that they're not available. But there are a lot of responsible gun owners, and every case needs to be evaluated individually. Okay.
All right, our long-distance caregivers face a whole different set of problems from the caregiver living with the person. And this is one example, again, from a support group member that Adele and I interacted with for a long time. And this particular situation was a father living alone in his own home in northern Minnesota, and there's the caregiver here in Galveston, and wasn't ready to leave home. And there's a lot of pride, there's a lot of history in a home. And so, people a lot of times want to say, okay, we're going to let dad stay at home as long as possible. I think all of us want that, but we have to be realistic about what that means. And this man was still driving, had another driving issue, was determined to make it on his own. And his oldest daughter, the one that lived here, she would go up there every 2 to 3 months. She would fly up, check in. How's it going, Dad? I'm fine. Go home, everything's fine. And she would stay for a little while. I mean, their relationship was okay. It was pretty good. But there were other children, but they lived far away, but didn't have much contact with their dad, basically stayed in touch by phone. There was a brother that lived near the father, but he wasn't buying it. The brother was in denial about the dad's diagnosis of Alzheimer's, and he said, Dad's fine, look at him, he's still driving, it's all good. Well, as we all know, that's not the case. So the daughter, she made arrangements for her father's care. What did finally persuade him to get somebody to come in and help him in his home. And she paid this person. She had to start it out as the person was introduced as a maid, a housekeeper. That was more acceptable than somebody coming in to take care of me. I don't need somebody to take care of me, he would tell her. She said, well, let somebody come in and help you clean up the house and, just be around, give you a little companionship. That was how she got him to agree to it. She, in the meanwhile, with her dad's permission and cooperation, had taken over the bill paying, and so had made progress in that area. She got her dad to agree to be on his checking account, but he wouldn't give her power of attorney. Now, when we talk about powers of attorney with somebody with dementia, the time to make that designation is either before a person has any diagnosis or very early in the stages while they can still make a cognitive choice and agreement to having somebody take care of their finances and other business for them. And at this point, this gentleman would not do that for his daughter. She tried to get her siblings to help persuade dad or, give her some support. The sister said, oh, do whatever you think you need to do. We trust you. And dad, brother still said, Dad's fine. Mind your own business. He'll be fine. So she came to our support group here in Texas, caring for her dad 1,500 miles away. He, even during her frequent visits and with the caregiver in his home, he still wouldn't give up the keys to the truck. He eventually had an accident. It didn't injure him, but she was actually relieved because the truck was no longer drivable. But that was still a big risk to take with this man still driving. He fired the paid caregiver. Fortunately, she had found a person that understood about memory loss, about dementia. He would fire her. She'd go, okay, and she'd come back in a few days. How you doing today, Mr. Smith? I'm here to help you clean the house and stuff. And she'd come back. So again, the daughter was very fortunate to have someone who understood, and this person kept caring for him. The daughter basically exhausted herself, traveling back and forth, trying to make these arrangements with the caregiver, managing his bills for him, and not getting any support from her siblings. So at one point, her dad had declined to where she actually got him to agree to move to an assisted living. And he was initially very hesitant, but she described the assisted living as a very small facility. He felt like it was another home he was going to, and he did accept it. It was in his hometown. And the beauty of it, and this is another consideration that we urge caregivers to think about, is when somebody makes a move to some kind of residential care, do they have different levels of care than the one you're needing immediately? Because making that move later on with the cognitive decline is much more difficult. In this case, she found an assisted living community that offered all the levels of care, even through hospice care and end-of-life care. So she felt very comfortable in knowing that most likely he would never have to move again. And that helped her gain confidence in making that decision to get him in there. So she gained peace of mind, and her dad was now safe and secure in a place where he could be monitored 24 hours a day. And so in the end, that was a success, but there were a lot of risks taken along that road in caring for her dad.
Okay, this next one was a joint effort. Commonly around the holidays, families gather, and residents here on the island went down into the valley to visit Mama, to have Thanksgiving or Christmas, whichever holiday it was. And the whole family was gathering, and Mama was going to cook her food, and it was going to be wonderful. And the family arrives, and Mama says, huh? what? Why are you here? So the family realized there's something wrong. And they gathered Mama up, and they came to Galveston, and they contacted the geriatric clinic, got an appointment, came in, what do we do, what do we do? Told them about Libby's Place and the support group, and for about 3 or 4 months, the children attended the support group to get ideas on what to do.
They also got guidance from the geriatricians here at UTMB. There were a lot of medication changes that needed to be made. This woman had not been evaluated by a geriatric specialist yet. So that move made a huge difference in her care and in her functioning. When she first came to us at Libby's Place, she could barely function. She could barely walk down the hallway, not real responsive, very confused, very physically ill a lot of the time. When we got a hold of her medical records, and she just had a list of medications from many doctors, this long, and the geriatric clinic here was able to sort through all those medications, discontinue a lot of them and put her on the proper medications for her diagnosis and for her condition. And she greatly improved. This has been about 3.5 years ago, and she's still able to attend Libby's Place at this time and is actually doing quite well. Lives with one of her daughters. But this is a story of a family, and it is the the core family that made this a success, because they all banded together. And even though one daughter took the lead and said, yes, Mom can come live with me, but I need you to pick her up on this week, of this day of this week. I need you to take her for this week every so many months, because I need a break. And they lined it out, and they have all worked together between the daughters, the sons, the granddaughters, the granddaughter-in-laws. They all provide care for her, transportation care, respite for the primary caregiver that she lives with. And it has been a great success. It can happen, but it wasn't an easy transition. And it was their willingness to recognize the fact there's a problem, and we need to look at it. We can't just pretend that Mom's doing okay in her little house that we grew up in and everything's going to be fine. This family really made an intervention and improved I'm sure the longevity and the quality of their mother's life. So we like to share the good stuff too, the successes, because they're out there.
Yeah, they don't happen very often.
Yeah. But the way that some people reach success is what we tell them to do. What we teach people is to fill their toolbox. And they say, well, I don't have a toolbox. What are you talking about? And so that's where these resources and where the discussions, the support group comes in to play. And, it's not a physical toolbox. For some people it is. I have family members or caregivers that come in and they have a carry-along file box. And they can tell you who every doctor is, when the last visit was, the upcoming appointments, the medications, the medical history. They are the exception, they are not the rule. We encourage people, and we tell them all the time to do this, but honestly, how many of you could say right now that you have that information even about yourself? I don't.
Yeah.
So we teach it, and we try to expand that knowledge.
The toolbox can be a book that details various residential care settings with phone numbers and locations. It can be lists of various interventions to try with various behaviors. Everybody is different, and how they interact can be a challenge at times. The being aware of the different levels of care as life progresses, listening to friends and neighbors who are maybe further along the road, working with someone with dementia. It's important to know how much cash, what are the assets of the person, because frequently that's one of the first questions asked. What is the demented person's, what are their resources? Because that helps guide various options.
And we also touched on the legal matters and also advanced directives. Very important, especially as we get older for all of us. But if people come to see us and do not have any type of advance directive, we offer that information, the opportunity to fill out the forms. I know they're asked that when they go to any clinic, when they enter the hospital. They're also asked it in our daycare program. And so that is a very important part of that toolbox. And then you have your legal documents, your durable power of attorney, possibly guardianship if that's necessary, if it reaches, that level of need. But these are things that we talk about. It's important to have those conversations with people so they know there's options. It still amazes me how many caregivers come in and say, I don't know what to do. And I think finally, you've asked the question. And it's asking the question, seeking help. And if you're caring for a caregiver of an older adult with dementia or that person with dementia, and they're not asking the questions, to encourage them to. And we can be a resource. I'm a resource in the community. Adele is a resource here at UTMB. And then we're connected to all these other resources. Krista's here with the Alzheimer's Association. We have a lot available to us in our communities if we really look around us. And make a list, gather them up, and have them ready for when those questions arise.
As we've talked about the Libby support group, there are support groups on the mainland. Elder law attorneys are very important from the standpoint that Medicaid and VA benefits kind of all intertwine. And it's important to be positioned financially, optimally, to obtain the services that are going to be needed down the road. One attorney shared that there is a special exemption, and after all of the meetings I had gone to with elder law attorneys presenting, she was the first one that told me there is a special exemption that can be claimed that can protect up to $800,000 worth of assets from Medicaid. So if you've got a big estate, it's worth getting the advice of an attorney who knows those laws, the Medicaid law, and if the VA is in play, what the VA rules are. Wills and probate attorneys are not necessarily elder law attorneys, and there's a lot of confusion about that. Lots of online resources. The National Institute for Health, Institute for Aging, has multiple brochures, booklets on various health issues impacting all age groups, but they've got a large dementia section. Lots of resources. The Alzheimer's.org is a great place. Maybe your loved one doesn't have Alzheimer's, but there's resources there. There's information about other programs and such, and maybe links to frontotemporal dementia. So these are great places. The Senior Resource Guide, Alice loves it. She sends me stuff all the time. So.
Also, I want to mention the licensing agency, that I think sometimes people overlook the Texas Department of Aging and Disability Services. And they have just an endless array of resources, not only about the agencies and programs that they license and run, but other resources that, that they can share. And sometimes it's financial assistance, it might be home care, it could be somebody, people call me a lot looking for resources. They say, well, is there an adult daycare in Fredericksburg? I go on to the Texas Dad's website and they're all listed. Every licensed facility in the state of Texas is listed on that website. It'll tell you what their last survey results were, how large a facility it is, who owns it. All that's public information. There's no reason for us to not know that, and it's all there. That is a really great resource, that website, and I refer caregivers to it too. Mm-hmm. And then I tell them, go look at that. They say, well, is that a nice place? Is that a good place? And as a professional, I have to be careful about that. I always tell people, go visit a place, drop in. If you're not sure, drop in. Say, I'd like to take a tour around your place today. And pay attention to how they talk to you, how they talk to the people that live in the facility, if it's that type of facility. Of course, how it smells, how it looks. But it's a very personal journey. The caregiving, the decision making, what's ideal for one person may be the total opposite for the next. So a lot of times when people ask me for resources, I'll give them a list and then tell them, go visit it. Talk to the people there. You might like a big, active, facility with lots and lots of people, or you might like a smaller home-like environment. And fortunately, in this area, we have a lot of those options. So go see. What do you think? You know your husband better than anybody. What do you think they would most respond to? Do they have the types of activities and programs that they're interested in? That's all part of that exploration. So there's no one resource. We just try to keep up with the many that there are and to share them. And that's our short list, believe me.
Very short list.
Very short list.
There's a couple of final thoughts, but we do want to leave some time for questions or comments. Frequently, people will want to stick to traditions, the family traditions. And sometimes when it comes to dementia, mama can't cook her big meal anymore. So it's changing trying new traditions. Or maybe somebody else learning how to make the things that mama made every year. Caregivers must take care of themselves. If they can't take care of themselves, how are they going to take care of their loved one? And we spend a lot of time in the clinic watching for caregiver stress and trying to encourage the caregivers. If they like to go play golf, go play golf. Find somebody who can come and be present with your loved one, just to make sure that if there's an emergency, proper persons are notified. If they like going and getting manicures or pedicures, to do that, to spoil yourself, to take time for yourself. You have any?
Well,
comments,
I do have one
suggestions?
other thing I want to share, and I wish I'd have written this. If I had the time and energy, I might have. But in Forbes magazine, I found this on the internet. I'm always looking for new resources to share with people. And there was an article written about how caregiving can be transformed from burden to opportunity. And I thought, what a great way to look at caregiving. That's easy to say, so how do you do that? And this gentleman, his name's Anthony Cirillo, and he owns this company called Fast Forward Consulting, and he wrote up just this brief article about 7 key ways that stresses and burdens of caregiving can be lessened. But I just want to share part of it. The one that really struck me was he talked about people shifting their mindset. That caregiving doesn't have to be so negative and draining and turn your life upside down and you give your life up for another person, but that it can be an opportunity to give back and to create a closer, deeper personal bond with that person you care for, even though it might be a different kind of bond than you've experienced previously, to having a diagnosis that changes everything. And what he did was he said, let's talk to caregivers about following the 8 traits of elder people who experience a high quality of life. What are those 8 traits? And this is, from a bunch of different research, but here's those 8 traits. They said, number 1, we all need to have purpose. We need to stay active. We need to laugh every day. Even if you blow the punchline of the joke, just go through it anyway, okay? I'm with you on that. Learn something new, which we hope you have today. Nurture your friendships. Make a new friend. Foster a positive attitude. In the face of the greatest calamity, try to stay positive. Be grateful. It's so easy to see all the things we don't have and all the bad stuff, but there's got to be a grain of good in there or you wouldn't have gotten out of bed this morning. And the last one is to demonstrate love. And what greater opportunity is caregiving than to truly demonstrate love? So I just want to close with that. I think that's great advice. And I'm going to share this with a lot of people and find out a little bit more about this. But hopefully today has given you a little shift in your mindset about how you can either help caregivers, help our folks that we care for with memory loss. You've gained 2 new resources if you didn't already have us. And we're glad to share any other information or if you have questions or comments for us.
The name of the author of that article again?
His last name is Cirillo. It's Cirillo. His first name is Anthony, and it was in the Forbes online. Transforming caregiving from burden to opportunity.
The question was, how do we approach caregiving differently when dementia is not in play? And I don't know that there's a significant difference. There are different issues. And when I meet a new family, I tell them my goal is your goal. If your goal is to keep your loved one at home until the day they draw their last breath, that's where we're going. If your goal is, I can't do this, we've got to get my loved one into residential care, that's where we go. But I also acknowledge that just because today your goal is last breath in home doesn't mean that that could change down the road. Maybe not this year, maybe not next year, maybe in 5 years, that things beyond your control happen and you have to readdress that goal. And it seems to be more concrete assistance with people where dementia is not in play. How to get a provider, what are the resources to come in and help if necessary, programs in the community that the person might enjoy. It's more concrete versus the dementia being a little more theoretical and counseling.
And the resources are different. You mentioned that, and we can be helpful with that. We are focused on the dementia resources today, but we can also serve as a resource for those kind of things. The physical caregiving, is exhausting in a different way, but just as important as the emotional exhaustion, and it does need to be addressed, really in a lot of the same ways. The question is, what are the various levels in assisted living that a caregiver or patient might need to look at?
In the assisted living, it's graduated, and various facilities can go further. Some of the small assisted livings, they can handle basically one step beyond independent living, where really minimal supports are necessary, all the way to totally bedbound, where all needs have to be anticipated and taken care of. The bigger assisted living facilities may be very upfront with the family and say, okay, we can go this far. We can administer meds, we can help with bathing, but we are not 24-hour in-room bedside care. And so it's the families interviewing and trying to anticipate what their needs and expectations might be down the road. Occasionally I do get calls from patients who are in the large assisted livings that kind of look like independent living, and they're being kicked out because their needs have exceeded the facility's ability to provide care.
So it's asking those questions right from the start. What's your highest level of care? Because, and that's how they feel. They feel when they're being discharged, they're being kicked out. So exploring that right from the beginning is very important.
The question was about unfunded patients and assistance. Most all of my patients in the geriatric clinic have Medicare, at least. If they're low income, they've got Medicaid too. But there are younger people who have not been determined to be disabled yet that are out there struggling, and that's case by case, and we just have to get on the phones, get on the internet, look for programs and services that might benefit the person with what they need. So a lot of it depends on the reason that they're
situation,
unfunded.
Sometimes we're looking at like the people that, have never worked over here. And that's like,
Right.
so
Yeah.
they don't have Medicare.
And that's frequently talking with Social Security to find out if they have a family member that they can use their eligibility. Sometimes parents can ride along on a child's Social Security. But I don't work for Social Security, never have, I don't know what those rules are. So I encourage the families to schedule an appointment and go in and talk with the people who know. And the question was being admitted into a skilled nursing facility or long-term care. Long-term care. The long-term care facilities normally have skilled nursing aspects or skilled nursing wings. And they like people coming to them on skilled nursing from the hospital. They have to have, in order to qualify, a minimum of a 3-night admission in the hospital. Now, I get challenged when the patient came to the hospital and they might have been here 3 midnights, but they weren't admitted until the second day. So now they've only got 2 nights in the hospital as admission. Luckily, in Galveston County, we have facilities that are willing to work with patients who are being admitted from the community. They have not had that hospital admission, and are willing to work with Medicaid pending without requiring big down payments up front. Again, that's individual, and I talk with families individually about that because there's so many different things that come into play there. So there is possibility for people to go to long-term care if they don't have the skilled nursing aspect.
Okay, we gotta
Thank you.
wrap this up, but thank you very much.
Thank you.
Thank you.